Today's presentation will be presented by yours truly, and we are going over a study on patent ductus arteriosus, atrial septal defects, and ventricular septal defects. Our table of contents will include our introduction, our general description, our history, our etiology and epidemiology, our symptoms, treatments and therapies, studies conducted, and statement of learning and conclusion. Childbirth is truly a special moment, once the pain is over, of course. However, it can be a two-way road. Not everyone is lucky enough to pop out a healthy baby. Many things can go wrong and can be simple, such as the need for supplementary oxygen. Others can be more acute conditions that require drastic intervention. This research paper covers a study of patent ductus arteriosus, atrial septal defects, and ventricular septal defects. Anyone working with neonates in the field or even having a child would benefit from this information. And while there are many other possible disorders that can make the average hypochondriac never want to bear children, it's always best to start small and simple. Before we dive off too deep into it, take a minute to look at this picture. It'll help you have an idea of where the blood's flowing with each shunt. Well, what exactly are these disorders? They are congenital cardiac defects, or CCDs, that occur in more than 40,000 births in the United States. What is covered here is few of many. Starting off with the patent ductus arteriosus, it is literally a biological pipe. It serves as a shunt from the pulmonary artery to the aorta, bypassing the lungs. Some newborns have underlying issues or predisposed conditions that can cause complications or delay of the closure of the DA, making it patent. Another CCD, like atrial septal defect, can also occur with newborns. ASD is communication between the right and left atria. Some cases of ASD are able to resolve itself within the first year of life, and others require surgical intervention for closure. Finally, there are ventricular septal defects. Like ASDs, VSDs is also a communication between the left and right ventricles. Mild cases may resolve itself within the first 2 years of life, others require surgery, and some may require a restrictive band placed around the pulmonary artery. The history of these disorders can be quite interesting. PDA became suspect when Dr. Maud Abbott was presented 92 cases that, with what was confirmed with autopsy, showed patients that had PDA without any other cardiovascular abnormalities. All sorts of ideas were thrown into the pot to correct this defect, but it wasn't until 1938 when Dr. Robert Gross came along and performed the first successful ligation. Therapies advanced, such as balloon dilation of the pulmonary valve in 1953, the development of stents, cauterizing, and even catheter-based therapies. Those therapies, paired with new diagnostic techniques such as X-ray imaging or echocardiograms, went hand in hand in furthering the possibilities of intracardiac repair. Similar surgical interventions for ASD has also been available since 1953, about the same time. And VSDs were first discovered in 1879 by French pediatrician Henry Louis Roger, who was the first to correlate the clinical and pathological findings of the intraventricular septal defect. Before we skip towards the symptoms and treatments, it's best to know the etiology and epidemiology of these CCDs. PDA is associated with predisposing conditions such as prematurity, low birth weight, hypoxia, and a number of other possibilities. Ironically, it happens about twice as much in boys than it does in girls. As far as how often it occurs, it's about 8 in every 1,000 prematures. ASD's etiology and epidemiology doesn't really have much to go on due to the fact that the precise cause is unknown. What is documented, though, is that it accounts for approximately 13% of all patients with congenital heart defects, and that 1 in roughly 1,900 infants are born with ASD. VSDs are the most common congenital heart defect, occurring in most 50% of patients diagnosed with CHDs, and around 42 in every 10,000 are born with VSDs. Like ASDs, the precise causes of VSDs are also unknown. However, studies yield that VSDs are frequently associated to congenital diseases such as Down syndrome. Moving on, now that the etiology and epidemiology has been explained, it's safe to move towards the symptoms. Every case can and will vary from patient to patient. Symptoms can present at any age. Newborns with minor PDAs are usually asymptomatic and resolve itself in time. On the other hand, patients with moderate to large PDA show signs within 2 to 3 days as the left to right shunt increases. Symptoms of infants less than 3 weeks of life include tachypnea, dyspnea, and deferential cyanosis. Patients 3 to 6 weeks old have similar symptoms but include weight loss, failure to gain weight, hoarse cry or cough, atelectasis, and even pneumonia. Then you come across the unique patients who have reached adulthood with an undiagnosed PDA. Adult patients who have come with undiagnosed PDA yield symptoms such as congestive heart failure, atrial arrhythmias, and deferential cyanosis. Diagnoses of these PDAs are usually confirmed by echocardiographic imaging based on findings such as loud systolic or diastolic heart murmurs along the upper left sternal border. A patient with ASDs can present itself at any age with little symptoms and signs. Again, keep in mind that degree of severity yields different degree of symptoms. In some infants, depending on how big the shunt is between the atrias, symptoms include respiratory distress, heart failure, crackles, hepatomegaly, and tachypnea. In other patients, symptoms can include exercise intolerance, dyspnea, arrhythmias, and other secondary results from the abnormality. The classic heart murmur is also common in ASDs, and symptoms of ASDs are usually confirmed by echocardiography. VSDs are still similar to ASDs as far as the degree of abnormality to the severity of the symptoms and can present at any age. But often a minor case of VSDs can close on its own and signs and symptoms will never manifest. In cases that are moderate to severe, clinical manifestations can include tachycardia, tachypnea, increased work of breathing, failure to thrive, poor weight gain, and diaphoresis. Diagnosis of VSDs is also confirmed via echocardiography, and knowing the symptoms is vital to diagnosing and treating these CCDs. Now that we know what to look for, let's fix it. Once the knowledge of the clinical manifestations has been acquired, treatments and therapies are the next step to improving patient condition and life. In minor cases of PDA, intravenous indomethacin is the drug of choice for treatment or preventative. In more severe cases, surgery or ligation may be needed to permanently close the shunt. The treatment for ASDs is based on the symptoms and the size of the ASD. And catheter-based procedures or surgeries are required to repair the defect with a mortality rate that is lowest when the intervention is performed under the age of 25. VSDs, like the other CCCs discussed, have similar treatment options. Like the PDA, in minor cases, the patient's VSD should close within the first year of life as the heart grows in size and muscle mass. However, just like the other moderate to severe cases, surgical intervention is required. It may all sound short and sweet, but not all treatments succeed and more invasive means are necessary. But all the therapy-driven protocols are provided as needed. Like all diseases and disorders that plague mankind, there are plenty of new interesting studies that are conducted on the matter. For example, a recent study shows that cyclic stretching and stressing activates enzymes called GTPases, which are responsible for coordinating the heart's maturation during the embryonic stage. This lays the foundation for future methods, if the enzyme is released at the right time of development, to potentially retard valve malformation and possibly influence proper myocardial development itself. Another study in 2018 shows it may be possible to predict future heart complications in the birth mother for those who gave birth to infants with CHDs. Mothers who gave birth to babies with CHDs have a 19% chance higher risk of cardiovascular hospitalization, totaling the chance to 43%. Currently, there is a clinical trial being held evaluating the efficiency of remodeling, improving cardiopulmonary function in adults living with CHDs. Originally, I thought these CCDs were more or less the same as far as the results from left to right shunting, improper volume displacement, and abnormal chamber pressures. After researching, I've realized each one affects different areas, causing all sorts of variable side effects. Right to left shunts cause similar respiratory distress and cyanosis, but it differs from case to case and requires different interventions. ASDs and VSDs are basically underdeveloped myocardial septum tissue, making literal holes in the walls causing leaks of varying severity. As a future RRT, hopefully, I believe this information will be priceless due to the vital roles it plays in my career. If I can't fix the problem at hand with basic therapy-driven protocols, the problem must be deeper, like the heart perhaps. This concludes my presentation. I want to thank everyone for taking the time to sit down and have a listen.